is Radio Health Journal. I'm Reed Pemps. This week, the crisis of psychiatric patients overflowing emergency rooms.
People are on average waiting many hours, sometimes days, in some cases even weeks, untreated, and their symptoms tend to get worse.
Mental health in the ER when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy Radio Health Journal, you'll also like our sister show. Here's a preview of what they're covering on Viewpoints this week.
This week on Viewpoints.
The more I read about Roosevelt, and there was always this woman just hovering at his shoulder, I thought, what a fabulous life she must have had. How interesting to work for Roosevelt in the White House during that tumultuous decade.
Missy LeHand, her legacy as FDR's right-hand woman lives on. Then,
Millicent Patrick had to make a monster that not only looked realistic, scared people, but had enough humanity in him that people would feel for him.
The previously untold story of a Hollywood icon. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station, iTunes and Stitcher.
For most patients, going to the emergency room is a once-in-a-great-while kind of thing. They have a physical injury or illness, and it's taken care of. But when patients suffering a psychiatric crisis come to the emergency department, the process is often different and much less effective.
The vast majority of ERs are not really well set up for these kind of patients, and they would agree with us that they're not well set up for these kind of patients. The numbers of patients have gone up so dramatically coming to ERs for psychiatric emergencies in the past decade. People coming to the ER for suicidal reasons alone have gone up over 400% in the last 10 years.
That's Dr. Scott Zeller, Vice President of Acute Psychiatry for Vituity, a provider of medical services to hospitals and other healthcare institutions.
It used to be that the standard way of treating somebody with a psychiatric emergency who came to the ER was, okay, we know this isn't the right place for the psych emergency. We're going to call and find an inpatient psychiatric bed, and we're just going to transfer them to that psych hospital. We'll make sure they're medically okay and safe and stable, and then we'll get them on their way to there. Now, that may have made sense 10 years ago when there was only a handful of psych patients coming to the ER, but with the dramatic rise to the point that there are now 1 out of 8 of every patients in the ER, there's just not enough inpatient beds to send these folks to if you're following that little rubric.
Mental health has been a huge issue that we're really seeing overflow into the emergency department. So about 1 out of 5 people will experience some degree of mental health problem in a given year, and about 1 out of 25 will experience some significant mental health illness.
Dr. Ann Zink is Medical Director for Emergency Medicine at Mat-Su Regional Medical Center in Palmer, Alaska.
And unfortunately, because of a whole series of issues, patients really aren't able to access care when they need it. And when they're not sure where else to go, they end up coming to the emergency department. That's oftentimes in the emergency department we feel as though we're the place where we see all public policy fail. When things in the system aren't working well, the emergency department becomes the overflow tank where patients end up and where we see problems arise and they build and they build. And we've really been seeing this mental health crisis building in the emergency department for the last about 10 years. It's really been escalating quickly. And it's gotten to a crisis point in numerous emergency departments across the country, including the one that I work in Alaska.
With nowhere to put so many patients in the ER and no real setup to treat them there, the result is inevitable, what's called boarding of patients.
We use the term boarding in the emergency department once the emergency physician has made a determination of what the next steps need to do for that patient or what they need to be, but we haven't yet been able to secure that next step. So patient comes in with abdominal pain and they need their appendix taken out. We call the surgeon, they try to get the operating room ready. And the time from when we decide, okay, this is the problem until they get upstairs to the operating room or upstairs to the inpatient side for other treatment or to inpatient psychiatric or to another facility that can treat them, that's considered boarding. So this is kind of this in-between time, which usually is anywhere from 30 minutes to a couple hours in an emergency department, depending on how full the hospital is and what else is going on. Boarding across the country in emergency departments has become a bigger and bigger problem, not only with mental health patients, but with patients needing ICU care or other sorts of care. But it's particularly challenging in the mental health world. And at that point, it really feels like purgatory. It's this weird in-between zone.
People are on average waiting many hours, sometimes days, in some cases even weeks to get transferred. And they're often sitting in the back of the emergency rooms, untreated, with limited ability to move around or take care of themselves. And their symptoms tend to get worse. The ER itself is not a great place for somebody in a psychiatric emergency. Let's say you're despondent or you're very paranoid. All of a sudden, you're either strapped to a gurney in a back hallway or trapped with a sitter or security guard. And there's a lot of scary noises and uniformed personnel running around and strange equipment and the kind of dangerous-looking knives and needles and things like that. And what we find is a lot of our patients' symptoms will actually get worse. It's not what we would call an environment conducive to healing.
It's not good for other patients in the emergency department either.
There's not enough beds to move the other people coming in for, whether they're having chest pain or flu symptoms or what have you. They're often forced to wait for the few remaining beds that are available in that ER. And sometimes that leads to long waits. Sometimes that's so frustrating that we have a situation known as leaving without being seen, where patients actually just kind of give up and they've been waiting for hours and they leave. So everybody kind of is suffering. It's not just the psych patients. The access to emergency care is suffering for other patients as well.
Zeller says experts aren't sure why the number of patients going to the ER for psychiatric help has gone up so much. He says often, if you call your psychiatrist's office when you're in crisis, you're likely to hear a message telling you to call 911.
The federal government defines a psychiatric emergency as a medical emergency. So going to the ER in and of itself is not incorrect.
But then if we have no place to admit them for an inpatient psychiatric treatment option, it becomes really challenging. So as patients wait in the emergency department, some emergency departments do have psychiatrists who come down and consult in the emergency department. Some have social workers. And unfortunately, it's a big mess of federal and state and insurance barriers that have made this system very broken and siloed, and these patients get stuck in the middle of it and oftentimes waiting in the emergency department.
Mental health crises have to be treated vastly differently than an acute injury or other physical crisis, where speed is most important. ERs are built for that. It's rare that ER personnel can step back and approach a psychiatric issue without an eye on the clock.
Majority of the treatment to mental health is really a personal relationship. And that is the one thing that we do not have time for or don't make time for in the emergency department. And so creating ways to create better personal relationships in the emergency department can make a huge difference. One of my all-time favorite patient interactions was a patient who came in with abdominal pain, was very nervous. The longer I talked to her, it was very similar to this other patient I talked to. And it was clear that this was anxiety. And it wasn't really busy that day, so I was able to sit down and really talk to her. And I explained to her what anxiety is and how it can feel and what she can do to kind of help treat it. And she just burst into tears, and she said that she's paid thousands of dollars in copays. She's gone to emergency department after emergency department. She's never figured out what's going on. This is the first time anything made sense to her, and that she felt like she could make a difference and she could get out of the cycle now. So this was a really simple intervention of being able to spend more time with her. But unfortunately, in the emergency department, we don't always have that time. We got to create ways to find better time.
Zink says pushing relevant information about psychiatric patients to doctors immediately could have the effect of creating more time. In a few locations, completely new kinds of emergency department programs have been installed that give psychiatric health the resources it needs, including time. Zeller created one of the most well-known solutions.
I originally created something that became known as the Alameda model, which is calling for hospital-level psychiatric ERs, completely separate ERs for psychiatric patients, but that is nonetheless at the hospital level of care, so it's not something where people can say, oh, you're too acute for us. This is where the highest acuity patients will go. And with that work, we were able to demonstrate that we could practically eliminate psychiatric patient boarding in all area emergency departments. And we are also able to provide a superior level of care for these patients, so much so that we were able to stabilize and discharge 75% of them in less than 24 hours. When most of those folks would still be waiting for transfer to another site 24 hours later. We'd already have them back home or somewhere safe.
Zeller says the Alameda model has evolved and been refined to what he now calls the EMPATH concept, the acronym standing for Emergency Psychiatric Assessment, Treatment, and Healing. The first step is assessment. Part of that is to make sure the patient is medically stable. If the problem is psychological, not medical, the patient would go into the empath treatment unit, which looks about as different from the ER as it can be.
Rather than everybody being in an individual cubicle or locked room with security, we have one large room where everybody gets their own recliner, which can fold flat if they want to take a nap, or they can sit up and participate in direct treatment or group therapy or what have you. People with emergency psych conditions often feel confined or claustrophobic, and so these units are designed so that if they want to walk around, that's fine. They can move about all they wish. They can choose where to sit. There's other places they can go and watch television or read or play board games with staff or some of the other patients. All these are designed to help people relax, feel safe, and engage people in treatment rather than use coercion for treatment. And historically, too much of emergency or acute psychiatric care has been modeled on coercion. A lot of, we're going to lock you into this place, you're going to do what we say, and that's how you get out of here.
The results are also dramatically different than in a traditional ER.
In a traditional ER with that kind of disruptive setting, where 25% or more of these highly acute patients would end up physically restrained to beds. In empath units, usually we're averaging about 1 out of every 1,000 patients goes into physical restraint. So we drop down from 25% to 0.1%, which is a really nice improvement and kind of changes the whole dynamic of how we're working with patients. So in the empath units, we're seeing 80% or more of patients get much better in less than 24 hours and can go somewhere like home. Only 20% of the folks or less end up still needing to be hospitalized, but even those folks have 24 hours of treatment under their belt. They're able to go to an inpatient unit that's ready to accept them because it already has a lot of documentation and understanding how people are responding. Since we're making much more judicious use of those precious inpatient beds, there's probably going to be more of them available.
Such a program would also make more money available if government were more willing to support and reimburse. Unfortunately, Zeller says Medicaid and Medicare are especially inconsistent at funding mental health treatment. Private insurance is sometimes not much better.
It's really frustrating because this is an incredibly cost-effective and an incredible return on investment for anybody who's paying for the care of these patients, because for every $5,000 you pay us, we're going to save you $40,000 by giving them much more immediate, much more high-quality care in an appropriate location. I mean, it seems like a no-brainer.
But will that kind of program spread when, as Zink says, the ultimate problem is we don't consider mental health issues to be as important as physical health?
I think it's really difficult because I think we don't understand mental illness well. I think that we have a lot of stigma associated with it. There's a lot of blame. There's a lot of times patients and family will say, well, just don't be depressed. The world's not that bad. You should be okay. Or this is just anxiety. You just need to stop this. And I think it's important for people to realize that anxiety and depression and schizophrenia and bipolar are just as real of a disease as diabetes, as hypertension, as a heart attack, as a broken bone. It's just harder for us to see it, and we don't have as many good treatment options. So I think because we don't understand it well and can't treat it well, we try to push it off to the side, or we have traditionally pushed it off to the side in numerous ways.
Equal treatment is what's most important, and that will come with acceptance that mental illness is a disease. You can find out more about all of our guests on our website, radiohealthjournal.net. I'm Reed Pence.
Coming up, misunderstanding heart attacks when Radio Health Journal continues.
Paid non-attorney spokesperson paid for by the Sentinel Group. Attention military vets and current soldiers who served between 2002 to 2016. Have you or a loved one suffered hearing loss or tinnitus after serving or while serving in the U.S. Armed Forces? You may be entitled to compensation. 3M, the manufacturer of earplugs made for combat, recently paid the government $9.1 million to settle a False Claims Act case for knowingly selling these defective earplugs for over a decade. Specifically, the United States argued that the manufacturer knew their earplugs were too short for proper insertion insertion into users' ears and that the earplugs could loosen and therefore didn't perform properly or reduce noise the way they should have. If you or a loved one suffered hearing loss or tinnitus after serving or while serving in the U.S. Armed Forces, you need to choose the right legal team that has the experience, support staff, and resources to seek the most compensation for your injuries. Call the Sentinel Group now for more information and a free case review. Call 800-655-6458. 800-655-6458. That's 800-655-6458.
Individuals and businesses with tax problems, listen carefully. Do you feel like you're losing control of your finances? If you owe over $10,000 in back taxes or have unfiled tax returns, we can help you take back control. The IRS is the largest and most aggressive collection agency in the world, and they can seize your bank accounts, garnish your paycheck, close your business, and file criminal charges. Take control of your tax problem now by calling the experts at U.S. Tax Shield and take advantage of the Fresh Start program and new laws that may allow us to negotiate a settlement for the lowest amount possible. Our team of tax attorneys and enrolled agents can stop collections and get you protected so you can take control of your financial future. U.S. Tax Shield offers a price protection guaranteed quote to get you protected today. U.S. Tax Shield is A+ rated with the Better Business Bureau, so call now. 800-568-1647. That's 800-568-1647. U.S. Tax Shield. 800-568-1647.
What are you going to do with your old car? You can try selling it, you could junk it, or you can donate it to Heritage for the Blind. Your car will be towed away for free and your donation is tax deductible. Just call 1-800-835-1478. Heritage for the Blind accepts cars, vans, trucks, and boats. It doesn't matter if your vehicle runs or not. It will be towed away for free, and you'll be supporting those that need help. Heritage for the Blind is a nonprofit organization that helps the visually impaired live fuller lives. Call right now to donate your car, and as a special thank you, you'll receive a free 3-day vacation voucher to over 50 locations. Call Heritage for the Blind right now. Call 1-800-835-1478. Donating is easy, and your vehicle is towed away for free. Plus, you'll get a free vacation voucher for donating. Call now, 1-800-835-1478. That's 1-800-835-1478.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Facebook and Twitter, and check iTunes for a library of past programs. Plus, you'll always find podcasts of our segments, information about our guests, and the latest health news at radiohealthjournal.net. Join us again next week for another edition of Radio Health Journal.